Okay, we're going to use about up to 10 minutes time for questions or comments. Shepard?
One of the things that we discuss over the years and in a recent paper some of you actually have is the question of whether in fact the interventions can be done universal first in populations for those people who respond and who show signs of symptoms. They get a second level intervention, and a third level for those that are selectively not responsive to the first two levels. So if you think about that from a public health perspective, at the universal level, we're dealing with all kids or the whole population. And for those at that level, there's a different hierarchical complexity and specificity about the precision, of the interventions compared to the more selective, which may look differently and be more responsive to another segment of the population. And these populations don't reveal themselves by the level of initial severity or the level of initial behavior. They may show up as non-responders to a universal and be apparent as in need of second level and third level, selective and indicated, and treatment, of course, to back up. So I wonder if that kind of framework would alter the way you think about this wonderfully productive investigation of methodologies and strategies.
Yeah. Well, thank you, Shep. So I think that's the kind of issues that the smart design tries to address, to try to develop and also to evaluate the sequence of intervention strategies. So starting from a universal intervention to identify a subset that needs more intensive follow-up, and then to deliver the follow-up. So some of the questions that the smart design could be used to address would include both the choice of the first-line intervention, the choice of the second-line intervention, and also when to switch and what indicators to use to switch. So there's a variety of potentials that those. This is a very new methodology that was developed about this past 10 to 15 years. I think has a lot of potential that it might be very useful for this type of research questions.
I just might add, I think that's an important point, and so one is kind of getting the right treatment to the right person. Another is I've heard a lot of talk here about costs, and I think one of the things that technology has the promise of doing is offering lower intensity treatments that are of lower cost, and so I think one of the things that we're investigating is looking at those in primary care in stepped care models. So offering patients initially kind of low intensity treatments and then monitoring their response, and then stepping them up to more intensive treatments, more intensive and more expensive treatments, and looking at essentially cost effectiveness as an outcome. And that's not been investigated. It's possible that delaying treatment also has costs, and it may not be the right thing to do, but I think that's sort of another. I think those models, you can also think of it not just from outcome, but also in terms of cost effectiveness.
Yeah, and
maybe if I can add a point. Yeah, one of the very fascinating features about the smart design is it does not just look at one stage at the same time, but it's integrated over time. So it's kind of like playing chess. So in chess, if you make a move that's good today, it might not be good tomorrow. So likewise, a good choice for the first line treatment by itself might not be a good way to start the treatment sequence, because the failure from the first stage treatment might actually be problematic in the second phase. So so in a sense, the development of the dynamic treatment algorithm goes through a backward induction, like how I guess the chess game. You have to look forward to see what is coming up next to decide what is a good move for today.
Yeah. Also, I wanted to just sort of have us think broadly about this one. You can sort of think about this. We've got three terms that David and I used in a paper recently in Journal on AIDS about interventions that are broadcast. The idea is you give them to everybody. This is exactly the way you get them, just like you get a TV program that's broadcast in here. We've gotten to the point where we're doing narrowcasting, so that these are interventions that are focused much more on those needs that people have. That's what Shep is indicating in here, these kind of specific interventions. But there's also a dynamic dimension in here that really gives the opportunities that David has, and we've been calling that time casting. That is we want to get to the time and place at which this intervention might be successful. So we no longer have this kind of limitation in the delivery of interventions that are only single things, that you have this very small menu in here. So the kind of dynamic settings that Bruce was talking about is exactly, I think, these kind of next stages of work that we have. And we have a freedom of looking at these kind of visualizations of what we would really do in practice for trying to deliver more effective programs in different settings in here. I know everybody's getting tired. I did want to mention something. I would like to have one of you talk about CBITS a little bit. Just mention the kind of horse race issues.
Take a second. So one of the, one of the things that actually this was a few years ago. There was an NIH workshop on evaluation methods for mHealth, behavioral intervention technologies, and Naiwa and I kind of started working on how to evaluate these kinds of technologies in deployment. So if we start thinking about, we can't do RCTs on 40,000 applications, and there are new ones all the time. So how can we begin to test these in real deployment? If we start thinking, that I think what's going to happen is that agencies can, healthcare providing organizations and so on, can start curating and making these applications available. It gives us then the opportunity to examine in real time, in real use, their outcomes. So if you think about a system that is deploying, let's just say, a variety of applications for a specific target. In primary care, maybe it would be obesity, right? So, they can select a number of applications that they think are going to work and then monitor them over time. And essentially in what Naiwa called an open panel horse race, they can be evaluated, and then when those applications that that demonstrate locally that they are not as effective as the other ones, they can essentially be dropped from the system, and then leave those that remain in the system until they prove that they aren't worthy. You can add, you can continue to add applications or treatments over time and into the system, and it can monitor them, continuously. And so what that does then is that it moves us, it allows us to preserve some of the benefits of RCTs, the randomization and so on, but it moves us from this longitudinal model of evaluation and then deployment to evaluating during deployment, more like post-marketing surveillance that we can monitor, because these all provide data. They provide data continuously, and we can access those data. We can monitor the utility of those, and then at the same time protect the interests of stakeholders, of consumers, patients, providers, payers. I think that's
good. Any other?
And that's a model that was published recently. I think the model was published in the American Journal of Preventive Medicine earlier this year, and we're continuing to work on the methodology behind that.
Good. David?
No, if you could talk a little bit more about the last thing you were talking about. You were talking about that a lot of our randomized trials are to decide about, was this something we could generalize rather than use locally. Could you talk some more about that last part you were talking about? Because a lot of the work that we do with communities is really collecting a lot of data that they use locally for decision making, et cetera. But we don't know how to think about that from a statistical or design standpoint.
Oh, thank you. That's the part that I wish I did not have to skip. So the notion here, I got fascinated about in recent years, is in implementation, quality improvement, dissemination. Very often, our collaborators in the service systems have some questions that need to be addressed, and usually those decisions are made by judgment, by the expert knowledge. I do see there's a potential room to do some local empirical investigations and maybe even small trials to try to make that decision. But there is a pessimism about this type of local investigations, sometimes referred to as this small n problem. Here, n being the lowercase n, small sample size problem. So say, for example, if we have a school with 500 students in the special ed program. If we want to do a traditional two-armed 5% significance, 80% power test to evaluate whether a new procedure works better than the existing procedure, and assuming the effect size of 0.1, the sample size required is 500. So the trial will put 250 into the current protocol and 250 into a new protocol. And that's perfectly fine for the export model when the purpose is to inform other schools. But here, if we are trying to help the specific school to answer the question, it's an absurd design, because by the time the trial is done, there are no students left to benefit from the knowledge, the local knowledge gain. So in the statistical literature, going back about 50 years, in the 60s, there used to be a fascinating literature that deals with not the small lowercase n problem, but the small uppercase n. The statistical terminology is finite patient horizon. It really just means a small population size. So the 500 for this local investigation, it's not the sample size, it's the population size. So that the literature did not go anywhere, because I think there was no real applications until recently, when my colleague Ken Chung and I realized that this is the question being really need to be answered for the local investigations that are becoming an issue, I think, in implementation dissemination. So our paper showed, for example, for the 500 students, the optimal design under some assumptions is to put 100 students into a local trial and 50 in the new protocol, 50 in the existing protocol, and then apply the better outcome, the one with the better outcome to the other 400 students. And as a Bayesian decision approach, and one of our findings was that it partly depends on what the local team already know. If there is compelling a priori knowledge or the prior information in favor of the new procedure, there's no need for a local investigation. We already know, so just go ahead with the new procedure. On the other extreme, if there is a compelling prior knowledge against a new procedure, then don't do it. We already know. But in between, there's a range of uncertainty when we don't really know whether the new procedure is going to be much better than the existing procedure or not. And in those situations, a local investigation can can be helpful. And one of our really interesting findings was when we are in equipoise, so the existing knowledge about the new procedure and the existing procedure is neutral, does not favor either one, then as I mentioned earlier, the optimal design under all assumption is to put 100 students into the local trial. But any local investigation is better than none. So if we did our calculation wrong and if we end up using 60 students into the local trial and 30 in each arm, it's still better than not doing any trial at all. So I hope that this distinction between the small capital N versus the small lowercase n could the methodology development hopefully will stimulate more local investigations that use empirical approaches to try to address the local issues, and I hope that will make our partners in the service systems, in the schools, are happier with us. And this is also empowering them to give them the opportunity to use their own data to try to address their questions. Thank you.
I think this is an innovative model for, as Naiwa said about local empowerment, and it's always the very first response that every community that I've gone to is, we're unlike everybody else. And so any other program that's been tested on this is not necessarily going to work for us. And it's a great kind of engagement kind of process in here, as opposed to doing something deliberate to the community that they don't necessarily want.
Yeah. So doing a local investigation and try it out might be a way to help generate the buy-in. Right. That, we tried it out and it seems to work well, so let's do it. So that I think it will be better receptivity to go for it. And
from a science point of view, the ironic thing about this is lots of local evaluations can produce generalizable knowledge as well, and that's an incredibly important opportunity in here to feedback. So we are out of time. I'm going to give Mary Jane back the reins.